Good evening, everyone. Welcome to our journal club for April 2023. We have a very wonderful guest with us tonight, Dr. Rick Clendaniel, and I will let him introduce himself a little more.
Good evening. I'm Dr. Rick Clendaniel. I am on faculty at the PT program at Duke and am in charge of the Vestibular Rehabilitation Competency-Based Course Series.
Awesome. Well, Rick, tonight we have a very interesting topic to discuss, and it's going to cover an article on which you are an author. And I wanted to mention, because I'm sure you have no memory of this, you were my very first vestibular course many moons ago, before Emory, which I also did take that Duke-based competency course that people like to call Emory still. But I also took a course from you. It was a weekend course in Connecticut. I didn't really know much about vestibular. I was working in acute care. I knew there was a lot of dizzy patients that the neurologists, who were wonderful, but they didn't know what to do with them when they came in to the ED or to the neuro floor, and they'd ruled out stroke. So I was excited to learn more, and there I fell in love with vestibular. So very cool.
So it's all my fault, right?
It's all your fault. I mean, you are probably to blame for, I would assume, many people falling in love with vestibular, not just me. So, be that as it may, our article title tonight is Self-Reported Measures Have a Stronger Association with Dizziness-Related Handicap Compared with Physical Tests in Persons with Persistent Dizziness. So, we're going to talk more about that. And I always like to start out here with a little bit of kind of an intro for those who are kind of just learning about vestibular conditions for the first time and don't know a lot. So we're just going to get everybody on the same page briefly. Our vestibular system is in our inner ear. It's a neighbor to the hearing structures. It helps us sense where we are as far as, position, movement, and our sense of balance. And with that, of course, we have to have connections from that sensor to the brain. And we need that brain to process that movement, to integrate that information from the inner ear sensor, along with all the information from our eyes and our joint sensors and lots of other input we might use to help us orient ourselves in the day-to-day. So it is true that dizziness is a common complaint. With 16% reporting dizziness or balance problems, and this comes directly from the article. And it is a common feature or symptom, if you will, in an acute vestibular disease, along with some possibility of other symptoms, imbalance, visual problems, nausea, that kind of thing. A lot of folks, when they have some sort of peripheral vestibular issue in the inner ear, it'll start to resolve itself, but 30% roughly develop persistent symptoms. And that's what we're going to talk about here. So for those who are not aware, there is a commonly used outcome measure called the Dizziness Handicap Inventory, which is developed to evaluate perceived dizziness and how it's impacting someone's life, essentially. And when they notice those symptoms, so how do you feel when you roll in bed, that sort of thing, right? And there's also a bunch of physical tests that can be done for patients with dizziness when we think it might be from the inner ear. And some of those are what we call instrumented tests, so using kind of specialized equipment, and some are kind of more physical tests that we might do hands-on. So I have my first question for you here, Dr. Clendaniel. When you think about the DHI, who is using that instrument, would you say? Who's using that outcome measure the most?
Everybody.
So physical therapists for sure, right?
So, yeah, we use it a lot for rehab. The audiologists oftentimes, not always, but oftentimes will use it as part of, if they're doing the vestibular function tests, we see it reported there as well. So those are probably the two primary folks that are using it. So rehab and then also in testing.
Got it. Perfect. So, the interesting thing is that this article points out is that the DHI does not necessarily have a strong relationship with diagnostic vestibular function tests, those kind of instrumented test findings. I know we're going to dig in more to that in the article, but can you speak to kind of your perception of that, or what is your kind of thoughts about that lack of relationship or less of a relationship?
It's actually not, I don't think it's that surprising. When you look at whether the vestibular function tests or our performance measures and our clinical exam and rehab evaluation, we're looking at physical performance and physical function of the vestibular system. The DHI is really looking at the individual's perception of how the dizziness is impacting their life. And just like people have different pain thresholds and pain affects people differently, same thing for dizziness. So it does. It's I'm not surprised that there's no correlation between the two.
Yeah, I think it's a struggle for some clinicians because they want validation to say to their patient, oh, look, here's these things wrong that totally match up with how you're feeling, right? And it would be maybe helpful for some folks to see a one-to-one there, right? But I think you're absolutely right. I think, the fact that our brains are really cool and really complicated, and how they kind of process and receive information and, all of the things that go into sensations. I always like to think about the patients who, occasionally think that vertigo is fun. I've had a couple. I mean, and other people obviously think it's the worst thing on the planet. So you definitely have a range there with what, in theory is the same sensation, right?
Yeah. Sorry.
That's all right. You got it. So, this is where this article kind of goes into a little bit of this dizziness-related handicap, maybe more associated with the perception, as you say, of signs and symptoms that have a direct impact on their day-to-day life. So, again, for background on the DHI, this is how it's scored. You're going to rate 0, 2, or 4, depending on how often you're experiencing something like, does looking up increase your symptoms? And then they add up those points, and basically the higher the number, the worse the patient is, perceiving how their symptoms are affecting their daily life or when they're noticing them. And so 100 out of 100 would be the highest score possible. I have gratefully not gotten too many of those in my career. So that's a little reassuring that hopefully people don't get that 11 out of 10 pain that they sometimes describe. We don't hopefully get too many 11 out of 10 dizzinesses, but they have shown that a severe DHI level shows a larger functional impairment on balance, confidence, and number of falls compared with patients presenting with a mild DHI score. So at the very least, we want to help these patients. These patients are perceiving a lot of symptom, and that can correlate certainly to some real risks like falling and, presumably potentially getting hurt with that. So in this particular article, you guys, or the article kind of was looking at a group of individuals between the ages of 18 and 70. They had perceived dizziness that had started abruptly and was lasting for at least 3 months. And although persistent postural perceptual dizziness is not called out in this article, there's a bit of a feel of that. Is that right, Dr. Clandaniel, here with this group?
Well, possibly. I mean, it would meet since they have had symptoms for more than 3 months, they would meet the time criteria for 3PD, but there are other characteristic symptoms that we associate with 3PD, and that's not it's not clear that all these folks have that. So.
Got it. Like sensitivity potentially to visual stimuli, things like that. That is often described. Gotcha. Okay, fair enough. So it's maybe in the neighborhood, not necessarily the exact house. Yeah. Fair enough. All right, good. they did describe that the dizziness did have to be initiated or exacerbated by movement for this group. And then there's lots of exclusion criteria. And the one that I wanted to ask about specifically was actually had plans for a treatment of BBV within 1 month. And I'm guessing that's because of potential recurrence, and you didn't necessarily want to capture an active BBV person in this group. Is that correct?
Yeah, basically, because since BBB is intermittent, can recur, can be treated quickly and get rid of symptoms. It was not they may have chronic symptoms in the fact that they've had BBPV for 3 months and haven't received treatment yet, but it's not the typical chronic cause of dizziness.
Fair enough. All right, that makes sense. Okay. So they did a bunch of tests on this group of persistent dizziness patients. So preferred and fast gait speed, or velocity, grip strength, an interesting global physiotherapy examination. That was new to me. I was wondering if you have ever used that or what your thoughts are about that particular exam.
So there's a little background to the study. So Lenny Christensen, who's the first author on the paper, is Norwegian. She's doing her PhD in Norway. And the global physiotherapy examination is kind of I guess it's probably a kind of a hallmark of Norwegian approach to movement and function. So they're trying to look at how well people move. So it's a series of tests, flexibility, strength, and things as best I understand it. So that's what the GPE is. But so if there are any Norwegians in the audience, they can explain it better. But yeah, it's part of their gestalt in terms of PT evaluation and treatment things.
I mean, it's cool. It's always good to know what's out there, even if it's not something we're actively using a lot in our practice. It's good to know what's there. All right, good. And then, of course, dizziness severity after head movements. And they had them, move their head at a 1 hertz speed for a minute, and then they gave a rating from 0 to 10, pretty classic numeric rating scale type situation that would be often, again, used for pain as well, and people do sometimes use it for dizziness in the clinic, and to get a sense of that. So those were some of the physical tests, and then they did quite a few psychological measures. The one that I definitely have the most familiarity with, and I'm guessing most people out here might say the same, would be the HADS, or the Hospital Anxiety and Depression Scale. And what I wanted to ask about this section was really just if you routinely give the HADS, or what are kind of your tips that you think that you maybe should have a patient take that, if at all, in your clinical experience?
To be honest with you, I've never given it.
Okay, fair. Yeah.
Probably should, but yeah, I just haven't. And just if people appear to be, if they seem to have anxiety or depression, just on clinical evaluation, we may talk about it and make some suggestions. But yeah, I don't routinely use the test.
Yeah, and I have to admit, I am the same. I think that perhaps, maybe I'm making a leap here, but if you have seen enough patients, you kind of know the patterns, right? So maybe more experience kind of lends itself to kind of hearing some key phrases that are probably even worked into that HADS that, we didn't realize we were kind of on the same page as the HADS, but we were, you know what I mean? So yeah. I hear you. It's hard because time is such an issue, I think, in examination, just depending on how they give their history or if they show up late or anything like that. So, yeah, I think the best utility of the HADS might be if you were newer or just kind of maybe felt like there was really something going on that needed a more formal, I'll say proof, but some kind of say, hey, primary care physician or whomever else is on the team, I am very concerned. Not only did they say this, but this is the number on it, or, we just kind of a little back up on that, right? All
Yeah, and
right.
it's also one of those things like, is that really in
It's a
our
gray
scope of
area,
practice,
right?
or
Yeah.
are
Yeah.
you playing in your sandbox, or are you stepping out of your sandbox into somebody else's?
Right. I mean, I think if you treat it as a screening, to me, it's not necessarily a bad thing to just say kind of
Right.
what we're already doing in our heads anyway, saying, I'm hearing some things I'm concerned about, like, and obviously
Yeah.
communicating clearly with the patient anyway to say, hey, I'm concerned, or, what do you think about this? I've actually had patients without taking this, but just kind of having that conversation. They're usually open or relieved, honestly, if I kind of mention
Yeah.
something or offer like, hey, there's a couple good therapists I know, or, any kind of like way to like give them resources. I feel like they're always really glad, actually. So, um, all right, moving forward, we have some fatigue, dizziness, severity, and quality of life measures in this article. Um, Again, I can't say that I use these regularly, other than I guess I at least had some vague familiarity with the vertigo symptom scale, short form, in other literature. I would just wonder about your thoughts on fatigue and, what your thoughts are as far as why that might be related to persistent dizziness.
Um, well, I think we certainly it. I think we commonly hear folks complaining of being fatigued or tired when they're dealing with dizziness on a day-to-day basis, and I don't know that anybody's measured that before. So that was one of the goals in Lene's overall study, was to look at that. So
Very
that's
good.
kind of why it was included here. But
Okay, great. All right, so as far as results, they did find that with increasing severity levels of the DHI, the participants demonstrated worse performance on a variety of physical and psychological and fatigue measures. But with that, after adjusting for age and sex, they found significant associations between total DHI and avoidance behavior, psychological distress, dizziness severity, quality of life, but not with any of those physical tests. So the flexibility test that was mentioned, grip strength, that sort of thing. So we're going to kind of have you maybe speak to this a little bit and what your thoughts are on the results of that.
again, the lack of correspondence with the physical measures is not really surprising. Um, and yeah, I guess, I think about the other components. Um, it certainly it makes sense to me that if somebody has higher levels of perceived dizziness, that it would have an effect on their quality of life.
Mm-hmm.
Yeah, it can cause psychological distress. Psychological distress can probably also um, cause a higher ranking on the DHI. Same thing for avoidance behavior. So I think the relationship makes sense to me. Again, it's a correlation, so it
Mm-hmm.
does not discuss causality,
Right.
um, and which one's leading which, or are they both intertwined, or whatever. So
Right. More complicated even than chicken and egg, but yes.
yeah,
Gotcha. All right. So the conclusions of this article were, for this study, it seems that the DHI could be complemented with physical tests to establish a more complete picture of the patient's complaints. And then, of course, as most good articles end, further studies are needed to establish which physical test would be the most appropriate. So I put the modified motion sensitivity test that I know that Lisa Husel-Gillig has been working on, and I think is close to publishing, hopefully, up because, most folks are probably familiar with the classic motion sensitivity test, or some people call it the motion sensitivity quotient, as a way to kind of get a sense of somewhat objectively getting a measure of what movements are bothering an individual, which we know can vary between patients who are perceiving dizziness with self-movement, which this group seemed to have, going on as a piece of their puzzle. And I just wondered, I don't know that this is the right physical test because I know that the head shaking one wasn't necessarily good, but that only captures one movement. So I wondered, this is me going out on a complete limb here. Do you think that this might kind of fall in that bucket? Are there other ones that you think maybe should be tested or explored?
I think what we're trying to say in the article and the conclusions is that you know, a combination of tests, both physical performance tests, whether you choose motion sensitivity tests, dynamic gait index, functional gait assessment, modified CAT-SIB, dynamic visual acuity, whatever you want to choose, those are appropriate measures for that patient in terms of their physical performance. They won't tell you how the patient is feeling, how they're doing on a day-to-day activities. So you need some other measure to do that. And the DHI is one of those measures. There are other ones that may be more appropriate for the given patient, either in addition to the DHI or I guess in its stead. So they've established that the ABC has this nice inverse correlation with the DHI. But again, the ABC is looking at your perception of balance and whether you're going to fall or not. And the DHI is not really looking at that per se. There are other measures that look at how well you do in your daily activities, which may correlate with the DHI to some degree. There are other measures that look at visual motion sensitivity and things like that. So again, I think you can kind of pick and choose what you want to use as those other outcome measures to look at the impact of the dizziness on the person's life or lifestyle.
And I find this most important in those patients who are what some would call high functioning, I suppose, like someone who's, generally been an exerciser, they don't necessarily, like they have good proprioception, they kind of know where their body's at, but they get some sort of vestibular event and they have this kind of lingering dizziness afterwards. And, so they might test pretty well in my experience for, on balance, because they're kind of able to use their strength and other aspects to kind of look decent on the balance tests. But it doesn't mean that they don't have a significant perception of symptoms, and that can be a group that I think folks have trouble either kind of writing goals for or, kind of like sorting out how do you kind of show progress and, how do you focus your treatment a little bit. So I think things like maybe the situational vertigo questionnaire, things that are kind of looking at if they have, visual motion sensitivity, kind of pulling that out a little more formally, maybe helps with both goal setting and treatment planning. Would you say that that's kind of the case?
Yeah, I think it's nice to measure changes, hopefully improvements, both on physical performance tests as well as the individual's perception of their symptoms and how it impacts their life.
Good. Yeah, so in a way, this article feels like, oh, of course, but I think this is the kind of topic that I like to talk about because I think it can, once you've seen a good volume of patients, you start to say, oh, like, this is kind of a toughie. Like, how do I, kind of suss this out? Like, if they look really great on the ABC, for example, like, well, I don't think I'm going to fall. I'm just really dizzy, right? So you have that group, right? Like, so they won't look great on the ABC, but, that's not necessarily addressing their root issue. Right.
And conversely, we have people who come in and they're really not dizzy. It's mainly balance issues, and they may or may not have a vestibular problem, or they may or may not have motion sensitivity. And those folks that aren't that dizzy, if that's what I'm getting from their history, then I'm more likely to give like the ABC or something like that than the
Sure.
DHI.
Because they're going to score great. So, all right, you're a 0 on that. I guess they, nothing
Yeah.
to work on there, right? No, I'm with you. I think that's two really good examples. And I think that's why it's tough when people kind of give, which I understand the efficiency of it, but kind of some sort of outcome measure up front, like while the person's out, like filling out their insurance paperwork or whatever else they have to fill out. It's tricky because you don't necessarily capture, what you maybe would have wanted to capture.
Right.
But, again, I understand sometimes it's just what you need to do, and hopefully it does. DHI does great for the majority, luckily, I think, for this group of patients. So, you just kind of do what you need to do after that, I guess, when they walk in the room, right? All right, so go ahead.
Nope, I was just agreeing with you.
I love it. All right. So we're going to talk a little about treatment for persistent dizziness. And this is sticky because, again, this group that the article was about did not necessarily specifically have persistent postural perceptual dizziness. But I think if we kind of talk about it broadly, I have some slides that kind of refer to that just because I pulled from other material I already have. But, I think that something that every clinician should agree on is you're doing your physical exam that you can based on how you've been trained to try to capture, signs of deficit, whether that's, go ahead.
I'm going to step out for 1 minute. I'll be right back.
No problem. I'll just continue on explaining. All right. So, you're going to do your physical exam, you're hopefully have a standardized flow of some kind that works for most of the time, as far as a head impulse test and your dynamic visual acuity test to look for signs of vestibular hypofunction, maybe additionally the vibration-induced nystagmus test or a head shake test. And then you're testing positionally, looking for signs of classic BPPV. And then you're looking for any central signs on your ocular motor exam. And of course, you're looking at balance, which is something that could be a problem with someone with any of those issues, whether it's, vestibular migraine or BPPV and so forth. But at the end of the day, for someone with persistent dizziness, they may look pretty good on a lot of those physical tests. So in that sort of case, this is where knowing the criteria for persistent postural perceptual dizziness, which we did talk about in August of last year with a really excellent prior journal club with Dr. Goebel. So feel free to check that out as well. But essentially, when we talk about treatment for this group, there's no BPV to clear at this point. That's been taken care of. Maybe they have a hypofunction and they did not adapt well, so you might be working on that. But it might be more, from other issues, again, kind of fluctuant issues, vestibular migraine, that kind of group that has this kind of persistent dizziness on a day-to-day basis. So a few things that we have seen from Janine Holmberg and Rachel Wellens in a talk they gave 2 years ago now at a American Physical Therapy Association convention. So this comes from Dr. Holmberg's and Dr. Wellens' lecture that they gave on 3PD. They talked about some things that I think are pretty widely applicable, even if you don't have an official 3PD diagnosis, as far as these pieces of a house. So they talked about it that way. So looking at the foundation, it's really a good idea, almost with any vestibular issue, perhaps, to talk about, okay, if the person's complaining of fatigue, just checking in on the sleep factor. I know it's obvious, but, how is your sleep? And, you can educate to a degree on sleep hygiene, and then we can always refer as needed if they need, formal assessment by a sleep specialist, right? And then exercise. I know physical therapists are renowned for recommending, at least take a walk outside, whatever they can do physically that would be safe, depending on, what level of dizziness and balance they're experiencing. How do you advise folks as far as aerobic activity, especially if they're complaining of significant dizziness or imbalance and a fear of falling if they walk outdoors or that kind of thing?
I just tell them to do it.
All right, just do it. All right. Nice.
We talk about, adjusting where they're walking, when they're walking, but get it to be progressively further / longer.
Excellent. Yeah. And I've had
Figure out what
people
they
go ahead.
no, just to kind of figure out what they can do to start
Right.
with, and just all right. Every day this week, you do that distance, whether it's a block or 2 blocks or 10 minutes or 15 minutes,
Or
and
laps around the inside of the house holding on to furniture. I'm really
yeah,
very
yeah.
open minded.
Um, and then yeah, and again, it depends on where they can walk. Um, and then just gradually try and increase it.
Yeah. And, when I encourage that aerobic activity, I sometimes, try to couch it as like your brain, is trying to heal, it needs to, hopefully, take movement better. Walking is both movement and gets blood flow to your brain. This is good, that kind of approach to like the why, as obvious as it might feel like that everyone needs exercise. I think when people are dizzy, they tend to feel like, oh, if I move, I'm going to make it worse, right? So this is kind of a challenging thing, right, to convince somebody sometimes.
Yeah, I mean there is evidence that aerobic exercise increases the release of this this molecule called BDNF. And then I'm blanking on
What
what
it
it
stands
stands for.
for. Yeah,
Brain-derived neurotrophic factor, I think, which
that's
actually
right.
promotes cell growth and synapse formation and it facilitates plasticity. So yeah, it's not a bad idea to I mean, doing aerobic exercise prior to doing your other exercises um, is a reasonable approach. There's some science behind that. So.
Excellent. No, that's a very good point. With that, or on its own, perhaps depending on how it works for the patient to learn, there's kind of breath work or relaxation work, and this is certainly, again, a complex relationship between the emotional centers of the brain, our vestibular centers, if you will. It's all almost, there's no centers to me. There's like kind of intertwined. But yes, they kind of have jobs, sort of, in the parts of the brain. And, to be able to, you know, and this is where it gets tricky again. People say, "Oh, well, you saying I'm anxious." Well, no. Like I always say, it would be normal for anyone to feel, you know, if you're feeling dizzy or you're feeling imbalanced, to then worry about that, or kind of reassuring them. I feel like is a part of our job as well. Do you have any additional thoughts on kind of that relaxation piece of this chronic dizziness type situation or persistent dizziness?
Yeah, I think there's several things that you mentioned. I think relaxation techniques are very good to teach people, especially folks with 3PD, because they get themselves in situations where that it aggravates their symptoms, increases their anxiety, and it just is this nice downward spiral or escalating event, depending how you want to think about it. But the other thing, for I think for all the patients that we see, but primarily for the folks with 3PD, a little bit of education goes a long way. If you can explain to them that, oh, the fact that you're bothered by things moving around you, that's not surprising because of your vestibular issue, you rely on visual cues, you have hypersensitivity to visual inputs, da 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 da. And so when you give them a physiologic reason for the
Mm-hmm.
symptoms that they're experiencing, I think it goes a long way to help them just relax overall and recognize that, okay, what I'm feeling is quote unquote normal given the experience I've had.
Right, right. Validation. It's huge. I definitely feel, for most vestibular patients, again, even the ones with just BPPV, they're like, oh, there are little things in my ear. Like they're like, whoa, right? So, yes, education is key. All right, I want to tap into the fatigue a little bit more. And I know there's some literature on this. And I pulled this just kind of as like a summary from vestibular.org. Why might people with any kind of vestibular disorder be vulnerable to fatigue? And you touched on this as well. So some theories involve the fact that the brain is often having to work harder because it's trying to manage symptoms. And sometimes when I talk to patients about kind of feeling off, it's an off feeling. There's a lot of times people, I turn my head and I feel off, like not just dizzy, but like, like a little, I call that the wait, where are we feeling? So I'm like, yeah, your brain is saying, wait, where are we? For like a second or a moment or whatever. So, the patient's usually like, yeah, that's it. That's a lot of work for the brain to start kind of constantly have to not have a good automatic pilot is another way I'll say, kind of it's a work a little harder to say, this is where we are in space right now. Okay. Yep. We're straight. Oh, we're lean, trying to figure that out essentially. And then of course the chronic stress of, having these unpleasant and sometimes unpredictable symptoms, it's going to be bad today, that kind of thing. Right. And then, just kind of the life pressure that you have to continue to function, even though you're feeling all of this and trying to figure out how to manage it. Is there anything else you want to tap into there on, kind of fatigue and patients with vestibular disorders?
Only that I think the brain, or keeping your balance and your sense of orientation is now much more, for these folks, is much more of a conscious level activity, subconscious. And so again, I think that's probably taking, if you will, quote unquote, mental energy or effort to do that.
Right.
Which may contribute to fatigue as well.
Absolutely. And then there are sometimes they're like, well, why am I tired? I haven't exercised or something. And I'm like, oh, well, think about if you studied, for 12 hours straight, or, how you can feel tired even though you weren't physically active, that it was more, again, the brain working, and people usually can click in with that. So a lot of pieces to that, just kind of helping people understand and again, maybe feel reassured. Right. So here are some strategies that I have read, and some of them, again, seem really obvious, but what I tell my patients is, like, right now, at least, you don't have as much leeway. Like, maybe you used to, like, cheat and stay up all night or not drink water and you just felt a little weird or off, but you were generally okay and you kind of got through. Now, like, if you do those things, you're probably going to feel, really bad, right? So, this is kind of just talking about, ways to maybe educate your patient or encourage them to check in with the basics. Do you spend some time sometimes talking about that with your patients, Dr. Clendaniel?
No, I should, but I don't.
True confessions of Dr. Clendaniel. All right, fair enough. I think, again, it probably depends on the patient. Some maybe don't need as much of that, and other ones, especially if they're not getting better, I feel like that's where I might tend to tap back to that and say, oh, like, they're like, oh, I've had a really bad week. Oh, anything specific I should know? Like, anything going on? Oh, yeah, like, really big stressful thing going on. Or, oh, yeah, I haven't slept in a week because of my, visiting cousin or whatever, just like, right.
I mean, I do talk to, not this specifically, but I do talk to them about the fact that, so two things. One, early on in the recovery process, people tend to have good days and bad days.
Mm-hmm.
And bad days typically follow a good day when they did a lot. So
Uh-huh.
and then they feel worse. But then the other thing I do talk to folks about is that stress of any sort will typically make your symptoms worse. That stress can be emotional stress. It can be physical stress. So lack of sleep, it's pollen season, your allergies are acting up, you have a cold or whatever. Any of those things can make your symptoms of dizziness worse.
And that stress isn't necessarily a bad thing, right? I had a person
Yeah,
once who said, "Oh, my daughter's getting married in a week, and we got a million things going on, and I'm really excited." But like, I'm like, okay, well, you're still managing a lot, even though it's like
yeah,
happy, right?
yeah,
Yeah,
yeah, and you can't avoid stress completely. So
right, right, absolutely. We definitely there are things in our life we cannot control that would be stressful. Um, all right. So another piece of the treatment house are kind of things to think about when we're taking care of patients with some sort of persistent dizziness. This is kind of an idea of sensory reweighting, kind of some core and stabilization work. Some people use the word grounding, things like this. Kind of really tapping into the proprioception is kind of usually how I generally think of this kind of section or area. And sometimes it's hard to tap into proprioception if you don't have, strength in your hips or core, for example. So, you don't have as much to access. Even if you could feel where you are, you don't have enough to like kind of kick in and kind of keep you in place. So, those are pretty key elements. And specifically sensory reweighting. So there's a lot of language that people might use. I mentioned the word grounding. Is there anything specific that you would say you find particularly useful or would recommend when you're kind of trying to help patients kind of set themselves to center?
no. um, yeah, I mean, I don't have good I don't have good clues for that. So I mean, I usually just have people working, if we're working on proprioception types things, it's really just trying to work on maintain their balance, upright stance with eyes closed
Mm-hmm.
as long as they can. And if they need additional somatosensory input, lightly touching a tabletop or a countertop or whatever can add to that, and then gradually trying to decrease that. But
Mm-hmm.
I mean, yeah, I mean, there are folks who talk about kind of keying into your feet and feeling the center of pressure moving through on your feet, and that's fine. It's just not something I routinely do. But and part of that's also my practice setting where I see people for an initial eval and send them home with home exercises and follow up with them probably 2 weeks later or so,
Mm.
just because of where they live relative to the distance. And Duke being a tertiary care center, oftentimes it's hours away. So,
Right. Right.
if I was seeing them on once a week or a couple times a week, then maybe I'd be doing things a little bit differently. But
Fair enough. Fair enough. No, that makes sense. And I think that tactile input, can be a good element. So you bring up a great point there. A lot of folks, they're kind of overly relying maybe on their vision, that could be a piece of it. And so I think the way that I usually try to tap in, and this is kind of a progression, but you're looking at different surfaces as well, right, to kind of have them be able to adjust to that. You mentioned eyes closed. Some folks use isometrics, which I thought was interesting. So this was a suggestion by another physiotherapist that I know that's in Canada, which is kind of a double win because you can get some good strength from isometrics if they're done regularly, and that might kind of help the patient again be more aware of their body. And you kind of mentioned feeling where your feet are and things. That's kind of like the body scan concept, which they sometimes use in yoga. Kind of feel where your feet are, your ankles over your feet, or your knees over your ankles, or your hips. So, just kind of getting people to check in. Probably not a bad thing to do. And I actually find that often it also is a bit calming. So I think that's like a double win. Um, you know, as they kind of feel that dizziness, and it just maybe kind of rules the day, as I like to say. Like, nothing else is really noticeable at that point. So if you can kind of pull away from that a little bit and, go into something else, that can maybe be a helpful thing. And then there's this concept of some patients needing this visual motion desensitization or habituation work. Ocular motor work could be mixed in there a little bit, kind of putting everything together. So being able to move the head, move the eyes, move the body, do more complex tasks like unloading the dishwasher is a good one. So you have to bend down, reach up, turn, all that sort of thing, right? And I think these are things that I find useful with habituation work if you're trying to get a patient used to movement is, that you don't have to start them out with, 10 minutes of spinning around really fast. That you got to, work them into it. And we actually had a nice question about this. So I'm going to hit that now that came in, from one of our registrants, which was if you could provide any kind of guidelines, and, we know that it should be individualized to the patient, but kind of how you might approach dosage, for lack of a better term, of habituation activities.
Yeah. So, general guidelines are any type of movement activity that provokes symptoms. So first of all, whether we're doing habituation types of exercises or if you're doing gait stability exercises, somebody with, for example, a unilateral vestibular loss, you would expect that they would have an increase in their symptoms. And that's simply a reflection of the fact that we're stressing their vestibular system, which is what we need to do to try and make it, quote unquote, better or stronger. So one, I tell folks, I expect you to feel worse immediately after you do the exercise. But within 15, no more than 20 to 30 minutes, your symptoms should be back to baseline.
Mm-hmm.
If you can't function because you're so dizzy, if you're throwing up because you're so dizzy, etc., we're doing too much and we need to break it and to slow it down. And I'll have patients do the exercises in the clinic with me the first time and just see how they do. And 9 times out of 10, even if you're doing something like horizontal head shaking test, or if you just simply have them do 5 cycles of a rapid head rotation, they're like, oh my gosh, that's awful. And you're like, well, just give it a minute. And you start talking to them. And then like 2 minutes later, you just turn around to you and say, how do you feel now? I'm like, oh, I'm okay now. It's like,
Yeah.
see. But yeah, certainly no. Yeah. And initially I'll probably shoot for 5 to 10 minutes of increased symptoms and then go from there.
Mm-hmm.
But still, I don't want to be any longer than 15 to 20 minutes max.
Right. So it's a little trial and error for sure with the individual, I would say, in my experience. I kind of have a gauge based on how they did on my exam. If they were like real reactive to certain things, then you already know, okay, we're going to go from my dream would be 2 minutes, but we're going to start it, 10 seconds or 30 seconds or something light, because you can always, reel them up in a session or two, especially if you're lucky enough to see them pretty regularly, as opposed to make them feel really awful and they never come back.
Yeah.
Right. All right. So with this, you have these kind of lovely clinical practice guideline recommendations on vestibular hypofunction with how many minutes a day. But for habituation or someone with more of a persistent dizziness, would you say that you modify these or would consider doing so, or wouldn't necessarily kind of shoot for that time frame right away at least, or?
Yeah, so we don't know from the literature what's best for habituation types of exercises. And so if I'm really just focusing on trying to decrease their sensitivity to either head movements or visual motion, I'm doing shorter durations within each exercise session and ask them to do it 2 to 3 times a day. So yeah, the overall exposure to the head movement is probably less for that. And that's just kind of what I've done. Was recommended years ago that's kind of the way to do it, and patients seem to tolerate it. More is probably better, but again, you're looking at people who are really getting dizzy with the head movements, and so you have to kind of titrate it appropriately. So I'd rather do smaller bouts multiple times during the day than a longer bout once a day.
Definitely. All right. So with that, I've read you in 2010 at some article said once, or wrote, it was written in the article that sometimes, you're not going to get a formal, head shake, even in someone with a traditional hypofunction, let alone someone who needs habituation. So there's a lot of ways to kind of engage the person to do head turns. I myself have had folks, either integrated into their daily life, like, okay, when you're going to sort the laundry, make sure you're kind of going from here to here, and, and then talk about pacing with that activity. And some people find that easier to work into their lives than kind of traditional vestibular exercises. So I think that could be something useful. Also, making it fun, have it be games. I've had people who felt like they could barely turn their head, but then they're playing a memory game where I have them going back and forth. And, they do pretty well with that. Maybe a little bit of dizziness when they're done, but, they're just maybe distracted by the activity. I don't know, but it seems to be sometimes more helpful than a more formal exercise. Is there anything else you want to add to that?
No, not really. I mean, the more functional you make it, the more likely the patients are going to do it for the first thing, and probably the better the carryover to their daily activities than just the simple exercises. So.
Right, right. All right. So again, kind of this grounding and sensory reweighting. I did want to give a shout out to Lisa Farrell, who has a nice website that I think clinicians, if you're not aware, you should check out. Symmetry Alliance. She has a lot of really nice free resources on there, span from meditation to kind of more vestibular type resources, educational pieces for patients, things like that. So that I just wanted to kind of put on this slide, as well as I'm aware that UCLA has a free mindfulness app. So if that's something that would help your patients because they respond well to apps, then that could be a way to go as a piece of their treatment puzzle. And some people do weighting when they do some grounding. I'm not aware of any formal literature on it. So I'm not specifically recommending it in any particular way, but I think that sometimes the patient just wants a little extra sensory input now and then. So it makes sense to me that as a tool in your toolbox, I'm always open to if a patient's responding well and it's no harm, I'm probably game. So I don't know if there's anything else on the sensory weighting piece that you want to add here.
No, not really.
Sounds good. All right. So the last thing I'll say as we wrap up these last couple slides is, I feel like some people, they want to habituate someone to motion, but if the patient just, was going to get better by just doing an activity that already bothered them, it probably would help them. So cueing the patient a little bit can be useful. And I heard this from, I think it was Dr. Pavlo, at the International Vestibular Conference in 2018. And she talked about if you're going to give them say a busy background or some kind of video, to hopefully have them in most cases have a task with that, whether that's gaze substitution or activine head movements or whatever you want to call that one, where you're kind of looking at one post-it note with a letter on it, let's say, and then switching your eyes to the other one, or maybe doing a light vestibular ocular reflex ×1 if you want to go that route, but it depends on the patient's again tolerance level. And then just kind of cueing them to maybe just try to not pay as much attention to the background, if that can help. I don't know if there's any other kind of thing you've heard on cueing or how you kind of talk patients through habituation at all, as far as visual motion specifically.
No, I think those are good cues to try and help people not, well, yeah, I guess ignore the movement in the background or the complex visual environments. The other way is to try and expose them to visual motion in a graded fashion. So, you know, start with small scenes that are moving and
Mm,
then increase the complexity of it or the size of it and complexity of it.
right. And just it's interesting sometimes, I'm sure you've had this too, where a patient hates the checkerboard but is fine with the lines, or is fine with the checkerboard but hates the lines, or,
Yeah.
um, they'll tell me that something really specific, like the ocean waves were bothering them when they were at the shore, but then they were fine with like a Home Depot, which would be someone else like really hates the Home Depot. So,
Yeah.
there's a little bit of individuality there as well, in my experience. And then I think this just kind of goes back to your recommendations to start light and to, I usually start with a static pattern before I go to videos. Is that something that you would say also is a tendency for habituation to visual pattern and movement?
Yeah. And I usually start with uh, not very complex visual backgrounds and then try and make them progressively more complex. So, I mean, for some people, even doing smooth pursuit activity, which generates the visual motion, even doing it against a kind of a plain painted wall can be symptom provoking for them. And so that's where we start. And then we turn around, look out into the room, or put a piece of wrapping paper on the wall in front of them and do it there. So they're increasing the complexity of the background.
Got it. These are just some resources for folks, ideas, beyond printed pieces of paper. You can use wrapping paper. I've seen people use a picnic blanket that was checkerboarded and putting it on the floor if you want to have them bend down towards it and come back up. There's so many different ways to kind of, I would say, pretty inexpensively, if you can't afford a really cool Burtec or anything like that, to try to, work with your patients, different light type activities, Christmas lights that blink, things like that. Some people get a disco ball in their clinic. Um, and then, of course, there's lots of great resources online. I always my go-to is Gabriel Pierce's. Um, got lots of good videos. Walking through Philly is always good for my patients since they're, you know, local to there. And Emory has a nice one as well with some videos that have optokinetic stimulation, things like that. So just want to offer these resources to our folks who are on here watching. And then, just to recognize that, at least for 3PD, and I would guess also for persistent dizziness in general, even though there may be some sort of emotional or psychological component that needs to be addressed, that a lot of patients need a few different elements and they may not always need the same elements. So some people, before you start any kind of habituation to move their head around, you've got to work on the neck because they're just been walking around like I call it Frankenstein, for 3 6 months. So if you don't kind of start to get the neck moving first, you're going to have trouble getting good, head movement for your vestibular activities and things like that. So multifactorial treatment is kind of something that you may have to think about for your patient situation. So this slide is just kind of summarizing how awesome Dr. Clendaniel is, and why we're so lucky to have him on. He literally co-wrote the book with Susan Herdman on vestibular rehabilitation. So if you don't have
I
one,
co I co-edited it. I didn't. We didn't write the
okay,
entire book.
okay. Details. You're on the cover, all right now. Yes, he co-edited, did a wonderful job. Really appreciative of that piece of literature. It's very helpful to a lot of vestibular clinicians. And then, of course, you're an educator working at Duke, board member for ABS, and your course that you help direct, or you're the primary director of, I should say, for Duke's Vestibular Rehab, a competency-based course. So lately, y'all have been doing two of those, one in the spring, physically in Atlanta at Emory, and one in the summer/fall at Salt Lake City. So for those who are interested in that course, I highly, highly recommend it. And there's a link there. I just make a short link because I think that's easier for folks there. So you guys can check that out and just watch for when they post up, when those courses dates are going to come up, and when registration is. Just keep an eye on the site. Does that seem like the right thing to do if folks are interested in that course, Dr. Clendaniel?
Yeah. The next course will be. We're not going to do one this summer/fall.
Okay,
The next one will be in March at Emory,
great.
at the conference center. And the
Sounds
dates
good.
are March 11th through the 16th. So
Okay.
Monday the 11th through Saturday the 16th, I think.
All
I
right.
think that's right.
Mark your calendars. Sounds good. Also, if you want to take courses from Dr. Glenn Daniel, otherwise, the educational resources, online courses are excellent. And for a free resource, you could watch the Talk Dizzy to Me podcast that he was on with Balancing Act resources. We're going to go ahead and switch to questions. All right, so our first question is, hi, this is Ritu from San Francisco. Has anyone used the PHQ-4 for screening anxiety and depression? I'm not familiar with that one. Are you, Dr. Clendaniel?
I know people do use it, but again, it's not something I've used.
Okay, great. Let's see. Besides us, vestibular PTs, are there any other medical specialists that you recommend referring to with some sort of 3PD? I believe she's referring to this diagnosis to help confirm. I often value having a mental health provider on the team.
Yeah. So I think the ideal, again, this doesn't happen very often, but the ideal composition of the vestibular team would be neurotologists, neurologists, PTs, OTs for the functional evaluation, the rehab component of it. Typically, audiologists are involved for testing for both vestibular function testing and hearing. And then somebody who can deal with anxiety, depression, those issues, whether it's psychiatrist, psychologist, some form of mental health provider. Yeah, that would be the ideal. So that way you've got the nervous system covered in terms of neurology and migraine and central disorders. You have the ear covered, and you have the psychiatric components covered as well.
Definitely. Another question that we had come through earlier was that patients recovering from persistent dizziness might even get to 95%, but sometimes computer screens still trigger their symptoms. Is there anything specific that can be done to address this?
Sometimes you can change sometimes playing around with the frequency of the refresh rate on the computer screen is helpful for some folks. Sometimes it's a question of changing the color scheme. Sometimes it's just get them to spend time scrolling through and use that as their habituation type of exercise. So those are the three things I'll usually look at with these folks. I had a woman who was a radiologist and had visual motion sensitivity, and I went into the radiology reading room just to see what that was like, and that is an eye-opening experience. They're in a dark room with these huge monitors, and they're scrolling through images, and so
Wow.
I mean, basically their only cue, since they're sitting perfectly still, is like this visual stuff moving in front of them. It was really disorienting. I mean, in her case, I actually recommended get a hard chair, not a cushion chair. Have your feet planted firmly on the ground. Try and get some of those proprioceptive cues to counteract the visual motion. But I mean, it was just shades of gray just going by all day long.
Wow.
I was dizzy after about 10 minutes in there, but yeah.
Fair enough. Yeah. And I think for not as dark environments, I've heard some folks recommend the 20-20-20 rule, which is really a good thing to do anyway, just to look away from the screen, out into your
Yeah.
environment for at least 20 seconds at an object 20 feet away, just kind of something to like reset button the brain a little bit, because sometimes it's just, you got to catch up processing.
Yeah.
It's a lot to look at. So, good thoughts on that. That's really helpful. Is there a differential test? That's another question that came through, to screen for dizziness from illicit drug use versus other causes of dizziness that we as physical therapists can do. I sometimes have teenage concussion patients that I occasionally suspect are on drugs that may be causing their dizziness.
I have no idea. Sorry.
That's okay. No, I didn't either. I thought it was a good question, because obviously we can't forget that there are other causes of dizziness besides vestibular issues.
Yeah. I mean, I would suspect that I would expect that you would, and this is just a guess, suspect that you would likely see central patterns of nystagmus, so like direction changing gaze event nystagmus primarily, or impaired smooth pursuit, things like that. I mean, I've seen folks who've not been on illicit drugs but have had high levels of I'm blanking on the name, anti seizure medication, and they've just had this unbelievably severe gaze evoked nystagmus. So again, not direction fixed, but direction changing, and it was all due to high levels of Delanton. I knew it would come to me sooner or later, but so yeah, things like that I think you may see, but yeah, other than that, I don't know. I'm not sure of a specific test or
Right.
oculomotor finding.
For sure. And that's where sometimes you obviously want to tap back to the doctors and other medical team. And if the patient, is just not, they're not kind of, again, it helps to be experienced, I suppose. Just like you see these patterns, you're like, oh, this doesn't feel like, vestibular dizziness. This is kind of, they're woozy and they're like out of it, maybe cognitively in a way that you kind of have that vibe. I mean, you can at least say I have concern or something like that, and then they can maybe explore it as a medical team. So I know we're over time. I'm the worst at that, but what can I say? I just love talking about vestibular stuff. So this is my weakness. But thank you so much, Dr. Clendaniel, for your time tonight. Really helpful, and really appreciate you for all that you've done for the vestibular community and research and education. So thank you very much.
It's my pleasure.
All right, everyone else, we'll see you next month, and have a good night.